A 65-year-old female with a history of neurogenic bladder and osteoporosis was referred to your clinic because she complained of bilateral cervical adenopathy along with night sweats. On physical exam, she was found to have cervical adenopathy bilaterally along with a spleen that measured approximately 2 centimeters below the left costal margin. Her ECOG performance status was 0. On her labs, she was found to have a slightly elevated white count of around 13,000. Her hemoglobin was 11.4, platelet count was 219, and her LDH was normal at 242. She had a biopsy of a cervical node, which showed a population of small cells along with some admixed centroblasts, and it was felt that her diagnosis was most consistent with a grade 3A follicular lymphoma. The cells, as we would expect, were CD10 positive, BCL2 positive, and CD19 positive. She had imaging studies, which included a PET scan, and on her PET scan, she was found to have enlarged nodes in the cervical region bilaterally, in the axilla, along with a small area that showed increased uptake in the liver. The maximum SUV was 9. She had a bone marrow biopsy as well, which also showed approximately 40% of cells that were small and had the same immunophenotype as her lymph node biopsy, and it was felt to be that this was consistent with follicular lymphoma in the bone marrow. So her FLIPI score was 4, and she was considered high risk. Her oncologist started her on a course of bendamustine and rituximab. She received 6 cycles, followed by 12 months of maintenance therapy with rituximab. After therapy, her best response was approximately 75% reduction in her total nodal volume, which would be a partial remission. This is not an uncommon presentation of follicular lymphoma. Many times patients present with low volume adenopathy, sometimes with night sweats. And many times patients, after we have staging, will find out there are many nodes that are outside of the areas that were initially felt on physical exam. For example, with this patient, we noted that there was an enlarged spleen on physical exam, as well as some axillary adenopathy and a spot in the liver. Because of the nature of this disease, follicular lymphoma grows very, very slow. And again, many times patients can have areas of involvement or enlarged nodes that are really only found on staging, which brings up staging. When patients are first seen in the clinic, we generally recommend full staging, and that would mean obtaining imaging studies really from the neck all the way down to at least the thighs. That can be done with a CT scan or a PET scan. We also recommend obtaining basic laboratory panels, which include looking at the patient's CBC, their differential, along with LDH. And finally, in most patients, to complete staging, we recommend obtaining a bone marrow biopsy with immunohistochemistry and flow cytometry.